This is Brent of the Brookbush Institute, and in this video we're going to go over a joint-based manual therapy technique. If you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed professional with joint-based techniques within your scope. That means osteopaths, chiropractors, physical therapists, you're probably all in the clear. Physical therapy assistants, athletic trainers, massage therapists, you need to check with your governing body in your state or region to see whether this is within your scope of practice. Personal trainers, this is definitely not within your scope of practice. Of course, all professions could use this video for purely educational purposes to help with learning biomechanics, anatomy, and of course palpation. In this video, we're going to go over anterior to posterior talus on tibia mobilization. I'm going to have my friend Melissa come out and she's going to help me demonstrate. Now, if I'm doing a joint mobilization, chances are I've already done some sort of passive accessory motion exam and I found stiffness in the direction I'm trying to mobilize. We could use convex on concave rules, and although they're not totally reliable for all joints, they work out pretty good for the ankle. Convex on concave would be glide opposite roll, so if I'm doing a posterior glide, that would help anterior roll, which would increase dorsiflexion, so maybe we want to use dorsiflexion as an assessment of the effectiveness of this technique. We could also look at the research, and I think if you guys look at the research on arthrokinematics and mobilizations of the ankle, the one consistent thing is anterior to posterior motion of the talus seems to get stiff, and that these anterior to posterior mobilizations generally increase function. Now, to show you guys this technique, I'm going to have Melissa go ahead and throw this leg off the table. I wouldn't normally do this technique with Melissa in that position. The thing you're going to find with all of our joint mobilizations, just as with all soft tissue techniques and even most exercises, is the more anatomy you know, the better off you are. So if you don't know some of the landmarks of the bones of the ankle, that would be a good thing to review before you start practicing these techniques. I'm going to show you guys where to find a few of them right off the bat here. So you can see the medial malleoli here, and then opposite the medial malleoli, although I know you can't see it at this angle, is the lateral malleoli. You should be able to find those two big bumps pretty easily, and you should be able to find the bottom of those bumps pretty easily. That's going to help with this technique. Another thing to find is the navicular tubercle, and that's a pretty sharp bump inferior and anterior to the medial malleoli. And then if I go inferior and posterior, invert her foot a little bit and go through that soft tissue, I can find the sustenaculum tali. And the reason why I'm trying to find all this is get myself familiar with where the talus is and the shape of the talus, because I need to find the neck of the talus. That's where I'm going to be applying my anterior to posterior force. Couple ways to find that. You guys can find the bottom of the medial malleoli, the bottom of the lateral malleoli, drop your web space down right over the line that you would draw between those 2 points, right in the angle of the ankle. Generally speaking, that'll put you right on top of the neck of the talus. Now, if you want to get more exacting, you could look for that space between the navicular tubercle and the anterior inferior portion of the medial malleoli, right? So you're going right between the navicular tubercle and the medial malleoli, and you can look for the convex surface in there. That's also the neck of the talus, and then you could follow that convex surface all the way around to the lateral malleoli. Of course, you got to jump over the, can you dorsiflex for me? You got to jump over this tibialis anterior tendon here, but there's a couple other tendons in there you got to jump over, but you guys can kind of feel that convex surface if you really want to get exacting about where you're going to put your web space, which is again over the neck of the talus. A comment on the web space here, guys. I know most people think that the web space is just a flap of skin and that it's not hard and that it'll feel fine for a joint mobilization, but you have to be a little bit more careful when you do these techniques. If you guys really stiffen out your hand like this and then go straight down, you decrease the surface area so much of your web space on their ankle here that it basically feels like a chisel going straight into bone. It actually hurts. You can actually really pinch somebody with your web space. So make sure that your hand is soft, right? Soft and supple, and that you're just going to flip your hand down. I would suggest that you press with this part of your web space not this part of your web space. All right, so you guys can see you flip your hand down just like this. All right, so we got our anatomy, and I'm already starting to explain the hand position here, but what am I going to do with this hand? How am I going to get my hand set up so that I'm ready to create this anterior to posterior force and potentially increase dorsiflexion? Well, you're also going to want to be able to control the foot and the calcaneus, which is fairly rigidly connected to the talus. I want you to take this hand and wrap it around the calcaneus this way. Right? So you gotta really hook the calcaneus there. Don't do this, because this will pull your fingers out and you'll struggle just to keep your hand from sliding off their ankle. If you hook this way, you'll get a nice good grip. I mean, you can feel like, I could feel like I could just tear Melissa's calcaneus right off, which I'm sure is exactly what you wanted to hear. But you need a nice firm grip, right? So you get a nice firm grip of the calcaneus, and then you need to do this little trick. Get your forearm underneath the ball of the foot. Right? So don't do this. This is tough. This is tough. You'll end up like trying to muscle stuff. Hook, come around, and now I can control dorsiflexion just like this. I lock out my elbow, and I can shift my weight back and forth. I don't have to muscle this at all. And I also, just with internal and external rotation of my arm, have great control over eversion and inversion. Now this hand goes right back where we were talking about. I can find my navicular tubercle, my medial malleoli, drop my web space right down in between there, pull into dorsiflexion. We do have some research that's starting to suggest that maybe we should be doing our joint mobilizations at our pain-free end range of motion if our goal is to increase range of motion. Right, so I could take her up to her first resistance barrier here. And now my hands are all set up. Hopefully you guys can kind of see how that is. Now you might notice that to get into position, right, so we got palpation, we got hand position. Let's talk about some body position here. Notice Melissa is lying and comfortable. That's fine. This is an easy technique. There's nothing major the patient has to do. Make sure their calcaneus is hanging off the table, because if you try to set up with their calcaneus on the table, as soon as you go to press down, you just end up smashing their calcaneus into your hand and pinching your fingers. That doesn't feel good. But notice how when I put myself into position, I had to lean forward. That is purposeful. So this isn't quite like a stretch where I want to stand straight up and then just lean sideways. What I want to do is create an anterior to posterior force. So I actually want some of my upper body mass over the top of my straightened arms, so that all I have to do is essentially rock this way. I'm not trying to muscle this mobilization, because that's going to wear out my hands. So calcaneus, ball of foot. All right, find my navicular tubercle, medial malleoli, drop my web space down, and I flattened that out and then kind of just left my hand supple. I leaned in to get as much dorsiflexion as I can take her into, first resistance barrier without pain. And now I'm leaned forward, so to start this oscillation, I just have to lean a little further. That's it. Now, a couple things that I'm going to want to think about before I start pushing as hard as I'm going to for this technique is, do I feel this tibialis anterior tendon popping me out of the neck of her talus? Right, we have to consider, go ahead and dorsiflex again, if she guards, essentially, if she doesn't want me to do this technique and she starts like contracting these muscles, I'm just going to end up mobilizing her tibialis anterior tendon. That's not necessarily going to be helpful if my goal is to increase arthrokinematic motion. So I need to be aware of that, and I think if you have somebody dorsiflex with your hand over the neck of their talus, you'll feel it pushes you right out. So make sure they're relaxed, and if you have to kind of reset, maybe start with a little less dorsiflexion, go for it. Maybe you're going to have to kind of give a few test oscillations before you really go into the technique, just to get them to relax. Maybe have them tell you a story, whatever you have to do to get their mind off what's going on here and get them to calm this muscle down. The other thing you could do, although it's not as common with this technique, is you do have your peroneal nerve, which if you shear it sometimes just the right way on this technique, as you put your hand into position, you'll stretch it, and that of course will give somebody a little singe or a little burn or that nerve sensation that just isn't very comfortable. Of course, if you do that, just reposition your hand. This technique isn't usually not a problem on this technique. So if you do happen to feel that, chances are you could move your hand a couple millimeters in any direction and that'll stop happening. So now what? All right, so I got my hand position, body position. Now we can talk about protocols. Now, I'm a Maitland trained certified orthopedic manual therapist. So what I learned was the grade 1, 2, 3, and 4 mobilizations, 1 to 2 oscillations per second, usually for 30 seconds to 2 minutes. Now, I don't want to make this a big thing about protocols. I think protocols should probably be tested to see which one is the best, but I would leave that to research. My big thing for you guys is all of these protocols tend to have a couple things in common, right? They tend to make sure that you find the first resistance barrier or the first sign of resistance as you're pushing down, and then of course the end of arthrokinematic range. So only far as you can glide the joint. And most of them do mobilization somewhere around 50%. That is 50% between that first resistance and the end of arthrokinematic range of motion. And then whatever protocol you're using, just finish it. The biggest mistake I see from students is they'll kind of go, all right, so 1 to 2 oscillations per second, 50%. All right, dorsiflex. And you're like, dude, that was like 7 oscillations, I think, maybe for 3 seconds. I think 30 seconds would probably be more appropriate for a Maitland style technique. And if you're using something else that, for example, is several 5-second holds, then do all of them and then retest. Just go through with your protocol. So again, if I'm going to use this Maitland protocol, I'm going to go ahead and get the calcaneus going. I'm going to bring my forearm around, which is on the ball of her foot. Now I have good control. I'm going to make sure she's in neutral for inversion and eversion. I'm going to put my hand in there in the neck of her talus, so right between navicular tubercle, medial malleoli, dorsiflex. Now again, I'm going to move her talus posteriorly. So I want to make sure I move all of her foot is going to come with me, right? Because we're going to move this whole thing on the tibia, which is now stabilized by the table. I'm going to find my first resistance barrier, which once I get through the table here is right about there. Then end of arthrokinematic range is there. Then back off to 50%. I'm just going to do some grade 3s here. All right, so this is just a little larger amplitude at 50% of resistance, and I'm going to keep going until I feel a reduction in arthrokinematic stiffness. You feel any nerve stuff? No. I don't feel her tibialis anterior tendon popping into my hand, so she's not guarding on me. All right, I'm just going to keep going until I feel like things are softening up. Now I could do grade 4s, all right? Start small oscillations right at 50%. I could go grade 4 plus and go a little closer to arthrokinematic end range. But again, these are just protocols. The big thing for you guys to get is hand position, understand the technique, understand your body position, start feeling arthrokinematic motion, and then staying consistent with whatever protocol you're going to use. Stay tuned for the close-up recap. Now for our close-up recap, you guys can see the lateral malleolus right here. And you can see this like indentation right here, right where the angle of the ankle is, where it changes direction. The neck of the talus is right underneath that. So you can see if I just slide my thumb underneath the lateral malleolus there, it almost puts my web space right on top of the neck of the talus naturally, so I can create that anterior to posterior force. Now, the other hand is going to go around the bottom of the calcaneus, and notice how I kind of hook the calcaneus like this, not only around from medial to lateral, but I kind of hook on top of it to superior. And then I'm going to bring my forearm around, so that I have good control of now eversion and inversion, which I'm going to keep that in neutral. I can bring Melissa into all of her available dorsiflexion. That's pain-free dorsiflexion. Now I can put this hand back over the neck of the talus, straighten out my arms, and I'm in good position to move her entire foot and talus as one unit so that I get a nice anterior to posterior mobilization of talus on tibia, which is supported by the table. We talked about watching out for the peroneal nerve, which sometimes, if you're not careful, you can kind of stretch or impinge on, and that causes a little bit of pain. And we talked about guarding. Melissa, go ahead and dorsiflex for me. All right, you guys see this right here? This right here is your tibialis anterior tendon that'll pop you right out of the neck of the talus. And you can even see here, this is the tendon of her extensor digitorum longus, and that will also pop you out of the neck of the talus. So be careful that they're not guarding, because that'll make it real hard to do your mobilization. But if we just slide in, once again, slide that hand over, forearm under, dorsiflexion, I can move through all, her foot all is one unit, through all available arthrokinematic range, noting here's my first resistance barrier, there's the end of arthrokinematic range, back off to 50%, and now I can do, like let's say a grade 3 mobilization, which is my larger amplitude from 0 resistance to 50%, 1 to 2 oscillations per second, until I feel a reduction in stiffness. To show you guys the other side, go ahead and drop this off. So again, this side comes around like this, right? Notice that these two fingers are actually superior to the calcaneus here, or the tuberosity of the calcaneus. And then I snake my forearm around. This finger ends up going right between the bottom of the medial malleolus and the tubercle of the navicular bone. Right? So you saw how my thumb went right under the lateral malleolus. My index finger goes right under the medial malleolus, and then my web space, which I'm going to flop down like this with nice soft hand, goes right over the neck of the talus, and I can move that whole foot as one unit, shearing the talus on the tibia. So there you have it. Assess, address, reassess. Make sure that every time you choose a joint-based manual therapy technique, it is based on an assessment, and that you return to that assessment after you finish the intervention to see if it was effective for the individual, the patient or client that you have in front of you. Ensure that you continue to learn your anatomy, because your anatomy is going to help you with your hand placement, with understanding what a joint can do, with understanding what you may gain from this particular technique, and of course, practice. You have to practice these techniques, hopefully not for the first time on a patient or client who just walked in the door. If you can, find a more senior instructor or a mentor to give you some really good hands-on instruction. Use your peers for some good feedback. And of course, always look for live education to help with your manual therapy techniques. I know these videos make education very convenient, but there is no substitute for learning manual therapy in a live setting. I look forward to talking to you guys again soon.